I'm Jabez, Paramedic Intern in Sundar Medical Foundation and Director of Medic Mode, a non-governmental organization for paramedics. So let's get into my talk. The title of my talk is The Paramedic Insight on Field. As I started my career as a paramedic, I faced certain challenges in the pre-hospital setting. Pre-hospital care is way more different from in-hospital care. Why pre-hospital setup is challenging than the in-hospital setting? Let's see. For example, if I want to see some exotic birds, I have two options. The first option, I will go to a birdlife sanctuary where gear such as telescope and binoculars will be available and the guidance needed for me to view the birds will also be readily available. The second option, I will go to a forest where I should equip myself with all the gears and the equipment, as well as I should also be cautious about the considerable risk and challenges which I will be facing in the wilderness. In our case, we'll consider the birdlife sanctuary as in-hospital care and the forest experience as pre-hospital care. In an in-hospital scenario, we have adequate team members such as paramedics, physicians, nurses, managers, social workers, technicians and patient transport personnel with precise roles to treat the patient appropriately in a medical emergency. In a pre-hospital setup, all these done single-handed by paramedics or EMTs. In most cases, only one paramedic and a pilot are assigned to an ambulance who has to multitask all the roles of a physician, nurses, paramedics, managers, social workers, technicians and even the patient transport personnel. Prioritize which a role to perform at the same time. Pre-hospital care is unpredictable most of the cases. Most ambulance pilots are only trained with basic life support skills. The pre-hospital setup is quite disconcerting because there are lots of eyes watching us. Paramedics will be surrounded with bystanders and the patient's relatives. At the point, we may get confused as to whom would know the patient's history accurately. In most Indian scenarios, a patient's relative decisions is given more importance than the patient's decision. Apart from the clinical intervention, the toughest task is to transport the patient. Even though we have all the patient transport equipment and the devices, it won't be suitable in all places. Unlike the hospital care, communication and decision-making skills play a major role in the pre-hospital care, which is as significant as clinical intervention. When I started to give attention to the emergency calls, I realized that this domain of pre-hospital care should be improved. Communication is a major pitfall in paramedics practice. As we paramedics focus on clinical intervention of the patient, we forget communication. Communication and fast decision making is the key to effective pre-hospital care. When there is a lack in appropriate communication, there will be a confusion in making decisions among the relatives. Communication and decision making are interlinked together and we need to apply both the skills at the same time in the pre-hospital setting. I would like to share an incident which I came through. One night, I got to attend an emergency call. The chief complaint was low blood sugar of an elderly male. I was dispatched from the hospital immediately. I was mentally preparing to treat an hypoglycemic victim. And I and my pilot arrived at the scene and one of the patient's relative signaled his hand to us to direct us to the apartment. The apartment stairs was too narrow and dark. Soon after reaching the victim, I started evaluating and found that he was in cardiac arrest. I was surrounded by nearly 15 members in the house. The one who directed us to the apartment was not with us. So I randomly called a person and explained the condition and started resuscitating. Throughout my resuscitating process, the relatives one by one came and was asking about the treatment of the hypoglycemia. I was hardly trying to explain them, but at a point it became chaotic and I ignored them and I was concentrating on resuscitating the patient. After a few attempts of resuscitation, I declared the victim to death. I was confused to whom I should share the news. There was many relatives and finally I explained to them about the process and returned to the hospital. I felt the communication was lacking with me. As there was too many confusion among the relatives, they couldn't rapidly take the decision for the medical intervention. Then I discussed about this incident with my colleagues and fellow paramedics and they also felt the same way. My ideas. I sat and thought how this can be improved, then I came up with some ideas. In my perspective, the first and foremost goal of a paramedic is to gain trust of the patient and their relative. By gaining their trust, it is quite easy to us to make them understand about the clinical intervention that we're going to improve the prognosis. In case if I am in a mute mode, then they couldn't understand what, and at the same time, they can't understand that my clinical intervention and the decision can improve the patient's prognosis. As I already said, communication and decision making is interlinked. The decision making related to communication when my decision towards the patient treatment and transportation is accepted by the patient and their relatives. The acceptance can be achieved only by communication. What is our on-field insight? Let's see. We cannot use a scripted way to communicate. We should adapt ourselves to the scene and we should communicate in such a way that it is acceptable to the patient and their relatives. We have a couple of guidelines for decision making in the pre-hospital setting and see how the decision making and communication is interlinked. The first one is the critical thinking process for paramedics. In the critical thinking of paramedics, we have 5 components. The first component is concept formation. Concept of formation refers to the information from the patient, such as chief complaint and history, and we'll also be seeing the scene assessment, initial assessment, and the physical examination. The second component is data interpretation. In the data interpretation, we'll be coming up with a working diagnosis with the help of the theory knowledge we are having from the anatomy, physiology, pathophysiology, and our clinical skills. If the paramedic is not sure of the working diagnosis, it's fine to call the physician on call. The third component is application of principle. From the working diagnosis, the paramedic should implement the treatment and through the help of local guidelines and protocols. The fourth component is evaluation. In this component, we should reassess the patient and find out the effectiveness of the clinical intervention which we have given to the patient. If necessary, we can change the working diagnosis and improve the treatment plan. The fifth component is reflection on action. In this component, we'll be debriefing the previous components and find out the pros and cons of the actions which we have made to the patient, which will be helpful us to improve us in the future events. The second guideline is 6 hours of clinical decision making in pre-hospital setting. The first component is read the scene. In this component, we'll be checking the scene safety, environmental conditions, and the mechanism of injury of the patient. The second component is read the patient. We'll be observing the patient, we'll be talking to them, we'll be examining them and find out the possible life threats and monitor the vitals. The third component is react. In this component, we come up with a working diagnosis and we'll be implementing a treatment plan. The fourth component is reevaluate. We will be reassessing the patient and do a focused examination and discover the problems. The fifth component is revise the treatment plan. After reassessing the patient, if we need to change the treatment plan, we can do that in this component. Sixth component is review performance. We will be re-examining our work and which will be helpful for us to improve ourselves in the future events. From both the guidelines, we will see how communication is involved. In the critical thinking process, 4 out of 5 components need communication. And in the 6 hours of clinical decision making, 4 out of 6 components need communication. Talking to the patient once or twice is not enough. Communication is a continued process throughout the pre-hospital scenario. Every single information can change the working diagnosis of the patient. If the communication is not effective, we may be misled even in the treatment plan. Effective communication is the key for fair decision making. We may already have a great communication skills, but still we may fall somewhere. These tips may help us to recall some important things and to remember while we are communicating to the patient or their relative. If there are too many relatives or bystanders, we can call 1 or 2 to communicate with the paramedic so that we may prevent the confusion and reduce the disturbance to the workflow. The second one, ask open-ended questions rather than close-ended one. And we should be a listener and we should not interrupt the relatives or the patient while they are talking. The third one, think before you speak. Using medical terms always is not useful. All persons will not be illiterate persons. Some will be illiterate or even the literate will not be aware of the medical terms. The fourth one, appearance and behavior. With the professional appearance and behavior and a neat attire, it is helpful to gain trust from the relatives and the patient. Be polite and calm while talking to the patient and their relative. Maintaining a proper eye contact. Maintaining proper eye contact will be helpful for us to gain their attention And maintaining the eye contact will not be useful in all the cases. In some cases, we'll be treating a critical patient, and while treating the patient, we'll be talking to them. So we should adapt to a scenario, as I already said. The next one is addressing the patient in appropriate and professional manner as they prefer. The next one is we should learn to be empathetic. The patient may be going through a lot of pain and agony, so we should think on their side so that it will be helpful for us to treat the patient. The last one is culture and language barriers. We may be working in some other states or country, so we should be aware and we should have some knowledge about the local language and the culture of the locality. Never provide false assurance. One is avoid interrupting the patient while they are talking too much. From all these things, we may know that how communication and decision making is interlinked. We cannot separate communication and decision making. The textbooks teach us communication separately and decision making separately. But on field, we should both interrelate and we should apply to the patients. So from this, the pre-hospital setting can be more effective.